Well, not by my watch.
Yeah, by every other time piece. You have a few more minutes.
Not more than one. Okay.
You need me for anything else?
No, that's great. Thank you very much.
You're welcome.
All right. Well, this is going to be a data-packed presentation, which is a little different, I think, from the way news about COVID-19 has been presented in the press and in the media. So get prepared for a data-intensive presentation. You might need a few extra sips of coffee to stay with me, and we're going to go through it somewhat quickly because there's so much, and I'm going to cover just about everything except vaccines. So if you have questions about vaccines, join me in the coffee hour after the service, because there won't be time at the end for questions. This is an outline, more or less, of what we're going to cover. And I'm going to use a joke as the inspirational introduction that we customarily use with the Sunday Forum. And this is the joke about the fellow who was experiencing a flood. The waters were rising. It was starting to come into the house. Along came an emergency vehicle. They offered to evacuate him. He said, "No, no, God will save me. I have faith in God." And so then the water rose more, and he was now in his second story window, and along came a boat offering to evacuate him. He says, "No, no, God will save me. I have faith in God." And then the water rose higher, and he was on the roof, and along came a helicopter offering to evacuate him. And he said, "No, no, no, God will save me. I have faith in God." And his next conversation was with God, asking God why he wasn't saved. And God said, "What do you mean I didn't save you? First I sent you a truck, then I sent you a boat, then I sent you a helicopter. What did you want? A winged chariot with angels? That's what you got." And we could reframe that, you know, God telling us that first I sent you masks, then I sent you social distancing, then I sent you vaccines. What did you want? Well, that introduces the way our nation has dealt with COVID-19, at least in part, I think. And now we're in the Omicron surge, or nearing the end of it. This is the graph of cases in yellow at the top, deaths in red just below that, test positivity, a little, or hospitalizations actually, a little below that, and test positivity at the bottom. So you can see that by three of those measures, we're approaching the end of the surge. Deaths are still going up, but that's because they lag behind cases by a couple of weeks. Our peak was about January 20th around here, but we still had 18 deaths in the past week. And this is where things stand at the moment. The US is approaching 80 million cases, and we are well over 900,000 deaths. But our test positivity rate has come down nationally from 25% to 8%. So we are at the tail end of this surge, even though only 65% of us are vaccinated. And you can see the numbers there for Nevada. In Washoe County, we've exceeded 100,000 cases and over 1,100 deaths. 22 people are still in the intensive care unit, 113 in our hospitals. Now the state has only counted 79, but I went through hospital by hospital counting the number of patients hospitalized, and I got a higher number, 113, as you can see. And our test positivity rate has come down from 32% to only 27%. So we're actually not quite as close to the end as the country as a whole may be. Now these are case fatality rates and also deaths per 100,000 population. And deaths per 100,000 population are on the left-hand side. And you can see that by both measures, Peru is really hammered. They've got a death rate of 642 per 100,000 population, just staggering. Whereas in the United States, we're at about 283 per 100,000. And as you can see, Japan has really done better than all of us by both measures. Now remember that the number of deaths is going to be a product of the case fatality rate and the number of cases. So that's why Mexico looks terrible in terms of case fatality rate, over 5%, whereas they're much farther down on deaths per 100,000, and that's because they've had fewer cases. Well, let me just review a little bit virology. I know we went through this the last time I gave this talk, but that was 18 months ago. You've forgotten some of this, I'm sure. I might even have forgotten some of it, but a virus is simply a hunk of RNA or DNA wrapped up in a protein capsid, may or may not have a lipid envelope over that. Lipid envelopes usually mean the virus is a little less stable in the environment. For example, polio can survive for many, many months, even a year in sewage, whereas SARS-CoV-2 is not going to. It may last only a matter of days. In spite of the fact that monitoring our sewage has actually become a very interesting and potentially powerful tool in detecting activity in the community. Viruses have no ability to replicate on their own. They depend entirely on the metabolic machinery of a cell that they infect. So they can only reproduce themselves inside the cell of another organism. The proteins are both structural and functional. The functional proteins, for example, in the case of SARS-CoV-2, are proteins that shut down the annoying normal functions of the cell that the virus is trying to replicate in. And those functional proteins also can turn on inflammatory responses to the virus that can be very harmful to the host. And that's what we call cytokine storm in the case of COVID-19. And that goes a long way toward contributing to the case fatality rate, in fact. Viruses have to have an attachment mechanism, a way of getting into the cell, in other words. They have to have a way to uncoat so that the RNA or DNA can get out, and then they employ what's called a polymerase to reproduce the virus itself. That has been a target for our antiviral program, as a matter of fact. We now have a new tool that is a protease inhibitor. And why is a protease important? Because it turns out the SARS-CoV-2 makes its proteins in long chains, all stuck together. And unless those chains, those polyproteins, are divided at the right place, the virus doesn't end up with the proteins it needs to assemble itself. So interfering with the virus's protease without interfering with human proteases is an important step forward in treatment. So how do coronaviruses fit into this? Well, first of all, they're positive sense RNA viruses, which means they can actually code from the RNA directly to proteins, whereas negative sense RNAs have to produce a positive sense RNA secondarily in order to accomplish that. They're enveloped, as I said. They're spherical with very characteristic club-like spikes on their surface. That's the spike protein that you've heard about. They're very large, non-segmented RNA genomes. We thought it wouldn't be quite as prone to mutation as influenza virus, which is segmented. It's got about 9 different pieces of RNA, all of which can recombine and exchange pieces of themselves with each other and result in a fairly rapid sequence of mutation. But it turns out that we were wrong at that guess from the beginning. There are 4 structural proteins, the one that comprises the spike, then the envelope, which is a glycoprotein, and the matrix and the nucleocapsid, which immediately surrounds the RNA and protects it. And then there's some 15 non-structural proteins. Well, this is what it looks like, and that electron micrograph on the left was taken by my mentor at CDC, Fred Murphy. He was a key member of the International Committee on the Nomenclature of Viruses because electron micrograph morphology is one of those 5 criteria by which viruses are classified. And on the right, another group has shown us a scanning electron micrograph of the surface of a cell, and you can see all of those little viruses attached to the cell, getting ready to penetrate. This is the Chinese rufous horseshoe bat, or Rhinolophus aphaenus. What a wonderful name. That horseshoe-shaped nose that you see there, if you look closely, is where it gets its common name. And this is the primary bat species from which SARS-CoV-2 and actually SARS-CoV-1 are derived. And I'm not going to get into the biology this time, like I did last time. You'll just have to remember that. So these are the coronaviruses. You can see there are 4 different groups, and there are 2 human viruses in the alpha coronavirus group that cause the common cold, 229E and NL63, and the other 2 are in the beta coronavirus group. Now, the beta coronavirus group is especially associated with bats, and it also is the source of the 3 serious high case fatality rate human illnesses, the Middle Eastern coronavirus or MERS, and then of course the original SARS virus, the serious adult respiratory syndrome, CoV-1. Now, let's shift now to the epidemiology. This is the beginning of the epidemic. You can see the new cases in blue were the initial epidemic in China emanating from Wuhan. And you can see that as it began to spread to the rest of the world, shown in yellow there, how quickly it took off, even as the Chinese were very successfully locking down their populations, restricting domestic travel, as well as international travel, and bringing their epidemic actually to a remarkable end. I think no one around the world, except maybe New Zealand, has been nearly as successful as the Chinese, but of course they have autocratic tools that we obviously do not have. And the Chinese were actually very generous in the beginning. First of all, determining the genetic sequence of this virus within a few days and sharing it immediately with the rest of the world, which I think has saved a great many lives. They also were able to describe the clinical features of the disease and its epidemiology, and to get that into scientific distribution very quickly, which helped all of us in dealing with this. So we learned very quickly about its transmission, how readily transmitted it was. And these are the transmission risks. Obviously, hospitals, especially those without personal protective equipment, obviously dangers in skilled nursing facilities, spread within households, other closed settings, the importance of close proximity, the role of loud talking and singing. You may remember that early in the epidemic, there was a church choir that met for rehearsal in Skagit, Washington. There were some 61 choir members present, and one of whom was infected, and their rehearsal resulted in 59 cases among the rest. Then there are the cruise ships, the prisons, the homeless shelters. The Chinese also taught us who was at greatest risk of severe disease. Those who had hypertension, we might not have guessed that one, diabetes more obviously, other chronic illnesses, chronic heart disease, kidney disease, lung disease, and of course, immunocompromise. The one risk factor that the Chinese missed that we learned from the British a few months later was obesity, probably because they didn't have a large population of obese persons. Now I want to shift to what we've learned about masks and their importance. And the Chinese taught us a great deal of this, not just on the mainland, but also Taiwan, and of course Singapore, and then the Koreans, and so forth. And I might just mention here that the Koreans did an interesting study in which they demonstrated that people wearing glasses were at significant, that is in combination with masks, were at significantly less risk than those who did not have glasses. And that's where the eye protective wear in our personal protective equipment in hospitals came from, is recognizing the virus can also get in through the conjunctiva of the eye. Well, these are laboratory studies that give us a sort of a hierarchy of the efficiency of masks. Obviously, the N95 masks are the most effective, and up to 98% effective in protecting against submicron particles like these viruses. The surgical mask is less effective. It can be made more effective by twisting the ear loop before it goes around the ear. That gives a tighter fit, and that seems to be why that works a little bit better, and also why ties work better than the ear loops. Now, what isn't shown here are the cloth masks, which are thought to be somewhat less effective than the surgical masks. However, if you put a cloth mask over a surgical mask, you can get up above 70% and more effectiveness. So this is a model which gives us an idea of the importance of masks in populations in reducing transmission. This is based on the R0, or as the Brits call it, the R0, which is the reproduction number. That is, for every case, one can on average expect 2.4 additional cases at the beginning of the epidemic. Now, in comparison, influenza has an R0 of about 1.4, measles of about 18. So viruses differ in terms of their transmissibility, obviously. And where you want to be is below an R0 of 1. That's when the epidemic starts to go away, if you can achieve that. And we've gotten close at points between surges in this epidemic, but we haven't quite gotten there. But you can see that adherence is graphed against the efficiency of the mask. So we're over on the right-hand side with a N95 mask that's about 95 to 98% effective, but obviously adherence has to be up well above 50% in order to get under that R0 of 1. So both adherence and the effectiveness of the mask are important. So that's a model, and models are sometimes accurate and sometimes not. So or are not, as you if you will. So here are actual field studies of mask effectiveness in the case of COVID-19. Now, we knew from mask studies with influenza how effective these masks were, but now we know specifically in the case of COVID-19, that is somewhere in the range of 70 to 79%, as you can see from those first three studies. The lower studies are population-based interventions with subsequent trend analysis. And as you can see, study of some almost 10,000 healthcare workers at the Mass General Hospital in Brigham in Boston showed that after the intervention, there was a daily decrease of about 1.3% per day of cases. In Kansas counties with a mask mandate and without, in comparison, those with the mandate saw a decrease in incidence of 0.08 per 100,000 population, as opposed to an increase of 0.11 per 100,000 in the counties without a mask mandate. A similar study was done in Arizona schools comparing those with and without a mask mandate. There was a 3.5 greater odds of an outbreak in schools without the mask mandate as compared to those with. Well, now I want to shift to the impact of COVID-19 on the healthcare system. As you can see, it's been exceedingly expensive. COVID-19 became the third leading cause of death in the United States, but deaths due to other illnesses also rose because of delayed or denied care or triage system, if you will. In 2021, almost 40% of hospitals were operating in the red because of the increased costs. You can see also that zip codes with a high minority or impoverished population were disproportionately affected. Now, this is the effect in 2020 of everyone's fear of the hospital. You can see that there was actually a tremendous drop in the spring of 2020 in admissions to the hospital. The blue line there is what would ordinarily be expected, and in fact what happened in 2019, the year before. And as you can see, there was a tremendous effect, not just in non-COVID admissions, but even in total admissions. Well, here's one example, namely cancer care. And as you can see, on the right-hand side, there are certain cancers for which delay in treatment, such as we saw because hospitals had to cut back on elective admissions in order to make room for COVID-19. Certainly emergencies like spinal cord compression or hypercalcemia, high-grade sarcomas, large lung masses, acute leukemias, the more aggressive lymphomas, head and neck cancers. All of these are associated with significant increase in risk of death with delayed treatment. There's some on the left-hand side, pardon me, that are a little less of concern. Other diseases affected, and you can see this is the peak in the spring of 2020 in deaths due to heart disease and due to diabetes. Those were the diagnoses most non-COVID-19 diagnoses most affected by COVID-19. A little less in the case of cerebrovascular disease, but remember, with a stroke, anticoagulant therapy, or actually clot dissolving therapy, has to occur within 3 hours of the onset of the stroke or it's not effective. So a delay beyond 3 hours of getting to the emergency room increases the risk of death from a stroke very substantially. So you can see that made a difference in the spring of 2020. COVID-19's also had an impact on mental health in the United States. The Kaiser Family Foundation in March of 2021 found that 24% of people had a close friend or family member die of COVID-19, and some 12% more knew someone who had died of COVID-19. So these are folks who you would expect to be stressed. And some 53% of these folks felt that their mental health had been affected, 30% in a major way. Each COVID-19 death leaves an average of 9 people bereaved. Lockdowns worsen domestic violence. In the case of China in 2020, the rates of domestic violence tripled. We know that's happened in the U.S. As well. And risk factors for a mental health impact oddly mostly affects the young, particularly those 18 to 24, but also women more than men, and especially women who have a child. Oddly, having 3 children or more seems to be a little bit protective. I guess the more children you have, the more resilient you have to become, or so it would seem. Pre-existing psychiatric illness is a risk factor, unemployment, and lower levels of education. Well, here are some specific mental health impacts, and you can see how they went up between June of 2019 and June of 2020. In the case of anxiety disorder, from 8% to 26%. In the case of depression, 6.5% to 24%. In the case of suicidal ideation, from 4% to almost 11%. Now, what about these stay-at-home orders that are so stressful? What about the lockdowns? And a point I want to make is not all lockdowns are the same. And there are multiple elements, any one or more of which might be chosen by a given country or jurisdiction. But what I want to emphasize here is the difference in numbers of cases, as you see on the upper left, numbers of positive tests on the upper right, and the death rate, or number of deaths, pardon me, on the bottom, in 4 Nordic countries, 3 of whom, Norway, Denmark, Finland, used some version of a lockdown in 2020. Sweden went the other way. Swedish epidemiologists argued, let's go for herd immunity. Let's let people get infected and become immune, and that will bring an end to the population. And you can see the price that the Swedes paid for that. And there's one in particular, Swedish economist, who argued vociferously for this approach, and we'll come back to him in a minute. So here are some differences among those 4 nations in terms of the public health interventions that they chose. And you can see that actually none of them is a complete lockdown. Only 2 of them used stay-at-home orders. 2 of them had a much more restrictive intervention on gatherings, as you can see, Norway and Denmark, than did either Finland or Sweden. You can see that the 3 successful Nordic countries closed schools. The Swedes just sort of recommended it, so it was a soft school closure. You can see that only 2 of the Nordic countries closed public transport, but the 3 successful ones closed work sites, and actually only 2 of them canceled public events. So there were differences, but as you can see, Norway, Denmark, and Finland all used multiple tools. So this is a study by an MIT group of economists looking at specific elements. And you can see that there is quite an effect of mandating masks, and I'm not going to take you through each of the elements, but you can also see the effect of a relative effect of no shutdown policies. Also notice that in the shaded area that represents the confidence limits of these findings, but even within those confidence limits, there is significant effect of having shut down or not having shut down, mandating masks or not mandating masks. Well, here are some of the more specific public health interventions. And as you can see, some of them are more effective than others, and some of them are less effective. And as you can see, during the summer, when transmission was highest, was the greatest effect. And by the end of that surge, everybody came out at about the same level. Well, recently there's been a lot of banter in the, particularly in the conservative media, about this study that's referred to as the Johns Hopkins study. Now, I think the people at the Johns Hopkins Coronavirus Resource Center are cringing at this being called a Johns Hopkins study. Only Steve Hanke is actually at Johns Hopkins, but he does publish this series of working papers on studies in applied economics. You can see that the other two actually are Scandinavian. There's Lars Jonung, who was one of the famous voices arguing for the Swedish approach to or hands-off approach to public health interventions and letting the epidemic go unimpeded in Sweden, and we saw what the effect of that was. Steve Hanke is also a senior fellow at the Libertarian Cato Institute, and Jonas Herby had also published a number of arguments against public health interventions. So these are all biased economists and not epidemiologists. And what they call the effects of lockdown is certainly questionable. So here are the problems. It's not a peer-reviewed study. They excluded some epidemiologic studies that they should have included. They failed to consider the fact that deaths lag 2 weeks behind transmission. They had sort of fluctuating definitions of what a lockdown was, but they started out with a definition that included any single non-pharmaceutical intervention. Obviously, comparing that to comprehensive interventions is just muddies the water. Now, they came to the conclusion that lockdowns, by their shifting definition, only reduced deaths by 0.2%. And that is strikingly in opposition to many of the very studies that they included in this meta-analysis. So it's hard to understand how they came to that conclusion. So a highly questionable study that isn't really even a study, it's a meta-analysis of other studies. Well, let's talk about variants. Obviously, Omicron has certainly gotten our attention, and we wonder, what is the next variant going to be? There are 9 letters left in the Greek alphabet, after all. So from the beginning, we learned that there was genomic drift in this virus, much more than we would have expected, knowing the characteristics of the virus that I talked about earlier. Now, the Shannon Diversity Index is actually a formula which I've shown you there just for fun. Al Fehrenberg can explain how the formula works if any of you want to bother him. But it's an interesting way of assessing genomic diversity in a given ecosystem, and that's the way it's been used. So this Edinburgh School of Medicine group, led by O'Toole, used it to apply to this virus. And the metaphor for the Shannon Diversity Index is the more different letters there are in a text string, the more difficult it becomes to predict what the next letter is going to be. So that idea can be applied to a genomic sequence. And so the more complex the genome, the more difficult it is to predict what the next mutation is going to be. So if you look at the left-hand side of the curve, you can see the Shannon diversity got very high very quickly. Also notice that within a very few months in 2020, we were up to 175 countries submitting genomic sequences. And we're now up to some 1,263 different genomic sequences of this virus. And notice in the middle graph there how far sequential genomic determinations have been from the original Wuhan strain. And the number of different lineages, genomic lineages, we've gotten up to within a few months, just in 2020. So now we're up to the Omicron variant. Now, to get a Greek letter assigned to you, you have to be not just a variant of interest, you have to rise to the level of variant of concern. So that's why there are so many other variants between these surges that just didn't make it until one broke through. Obviously alpha and beta and delta, and now Omicron. And you can see how quickly Omicron replaced Delta in South Africa, and the South African experience is instructive. Remembering that deaths lag behind cases by 2 weeks, and you can see that clearly in the June peak and the Delta wave last fall. The blue line is deaths. Actually, it's black or dark blue, I guess. And the hospitalizations in that pale violet, cases in orange. And you'll notice that deaths in South Africa did not peak 2 weeks after the peak in cases. And in fact, the case fatality rate fell from 8% to 0.2%. So a much more highly transmissible virus, which was associated with much less severe disease and a lower case fatality rate. Unfortunately, that case fatality rate is multiplied by a much larger number of cases. So we still have significant numbers of deaths, even with a low case fatality rate. So in South Africa, the duration of Delta wave was 5 months, comparable to us, but Omicron only 4 to 6 weeks. So that seems to be what we're seeing as Omicron goes away. Also there was Omicron is much more likely to affect people who don't have comorbidities than Delta, and the age has come down very substantially with Omicron. Well, Omicron's actually a family of lineages, and they were apparently all there in the beginning, BA1, 2, and 3. 3 seems to have just kind of not gotten any traction at all. And it looks like Omicron's actually a recombinant of 2 earlier lineages, a BA1, which was there long before the surge, and a very rare lineage called B35. And so it's the sequences of B35 incorporated into BA1 that led to the Omicron variant of concern. Now, the Wall Street Journal has put forth an interesting argument in the midst of the Omicron surge, pointing out, first of all, that excess deaths from suicide, homicide, overdose, and accidents were some 82,000 during the period they're talking about from March of 2020 to August 2021. Excess deaths from delayed hospital admission or procedures due to heart, lung disease, cancer, CVAs, some 86,000, and additional 56,000 deaths were seen in the 15 weeks up until mid-December. So they argue that with a case fatality rate near that of influenza, highly transmissible Omicron may actually reach enough of the unvaccinated and boost enough of the vaccinated to put us at herd immunity and curb the epidemic without lockdowns and allowing us to move on economically. So interesting argument. I'm not sure it's widely accepted in the scientific community, but it's food for thought, and serious thought, I think. So there are a couple of directions that this may go. And so the editors of the Wall Street Journal, looking at this from an economic standpoint, may be correct. Maybe there's not another surge coming. Maybe we are entering a period of endemicity, sort of a smoldering low-grade background of cases of COVID-19, primarily affecting the most vulnerable. And perhaps it is time to move on economically and maybe politically. On the other hand, the other possible direction is that 40% of the global population have been infected by Omicron. And remember, the larger the number of infected people, the greater the risk of emergence of a new variant. So there are 3 characteristics of a new variant that we have to be concerned about. One of those is more serious illness. We did not see that with Omicron, obviously. The other is immune escape. We did see that with Omicron. And the third is increased transmissibility. Those three features are the ones that concern us and raise a variant to the level of VOC, or variant of concern. Well, we do have some advances. Not so much in treatment. That was pretty well established in 2020. And we got better. By the end of 2020, a larger share of our patients in the intensive care unit were surviving. But little has changed since then. What has changed is options before patients are sick enough to be admitted to the hospital. Now, Remdesivir is actually the first antiviral drug developed for this virus, and it is it makes a significant difference in duration of hospitalization, a little difference in mortality. It interferes with the viral polymerase so that the virus is less able to reproduce itself. So what was sort of neglected early on in the race to find drugs to treat hospitalized patients with is that Remdesivir actually can be used in the outpatient arena. Now, we usually treat patients in the hospital with 5 days of daily IV infusions of Remdesivir, and that's effective. Well, it turns out that in mild cases, on an outpatient basis, though 3 infusions reduces the risk of hospitalization by about 85%. So that is an option, and one that we now need to begin to embrace. And I say that because the monoclonal antibodies by Regeneron, by Eli Lilly, that worked for the variants through Delta are not effective against Omicron. That's the immune escape that I was just talking about. But there is a new monoclonal antibody called Sotrovimab. It's a little less available than the older ones, but that should be changing. And that is effective against Omicron. There are 2 oral antiviral drugs that have just been authorized by the FDA and are likely to be actually approved soon. One is Molnupiravir. I haven't gotten used to the brand name yet of Lagevrio. It looked good early in the phase 3 trial. It actually looked very good. It looked like it was, 80 or 90% effective, but for some reason, they didn't stop the trial. And by the end of the trial, it looked like it was only about 30% effective. But it's very safe, except in pregnancy. Paxlovid, which is a combination of a protease inhibitor, so a new approach, no longer a polymerase inhibitor, but a protease inhibitor called Nirmatrelvir, is combined with an old anti-HIV drug called Retonavir, also a protease inhibitor, but it has no activity against SARS-CoV-2. It is used only to boost the Nirmatrelvir, in the Paxlovid combination. The 2 pills are taken separately. They come in a blister pack, side by side. You pop them out and take both pills. Unfortunately, the Nirmatrelvir doesn't last long enough to be effective in the blood and needs Retonavir, and that's the problem with this drug, and we'll get back to that. Evusheld is a remarkable new monoclonal antibody that lasts for 5 or 6 months, whereas in the past most monoclonal antibodies are gone in 4 to 6 weeks, and so they're only good for dealing with this episode. Evusheld is authorized for immunodeficient patients who are unable to respond to the vaccine, something we've desperately needed for that group of vulnerable patients. And that is available in the Renown Infusion Center. So we've been sending all of our immunodeficient deficient patients for that injectable monoclonal antibody. Now, there are problems with all of these. Obviously, the first two are IV. Molnupiravir is not as effective as you'd like, and we'll get into the problems with Paxlovid. But there is an antidepressant that costs $4 for a 5 or 10 day course, and it has proven effective in randomized trials. It's not been through a phase 3 trial, however, and it's not clear that it will be, but certainly more evidence is needed because it's cheap, it's readily available, it's already approved for depression. Side effects are minimal, particularly if you're only going to use it for 5 or 10 days. So that's kind of in our back pocket. Well, these are the differences between these 4 new authorized treatments for people with mild disease who might be, particularly those who might be at high risk for hospitalization, to prevent hospitalization. And as you can see, Paxlovid, Sotrovimab, Redesevere are all 85 to 88% effective. However, there are problems with drug interactions in the case of Paxlovid because of the Retonavir component. The protease inhibitor for the virus itself is not a problem, but the Retonavir used to boost it is, and I'll show you that in just a second. The Sotrovimab needs to be given within 10 days of onset. That shouldn't be a problem. Remdesivir cannot be used in liver failure or renal failure, and Molnupiravir can't be used in pregnancy or in women who are breastfeeding. So here's the Paxlovid. And the problem is that in order to boost the levels of the Metrovir, Retonavir is required to inhibit liver enzymes, both the, primarily the CYP3A4, which also affects a variety of the liver's ability to get rid of a variety of other drugs. So renal adjustments required. The Retonavir dose stays the same, but the pharmacist actually has to remove pills from the blister pack, or pills from the blister pack, in order to give you the reduced dose if your glomerular filtration rate is between 30 and 60. And of course, below 30, you don't want to use that drug at all. So these are the differences between the Metrovir and the Molnupiravir. In the case of the Metrovir, the virus produces its proteins in these long chains that have to be cleaved at exactly the right places to give the virus the component proteins that it needs, both to interfere with cell function and in order to assemble its structural proteins. Whereas the molnupiravir is interfering with the RNA polymerase of the virus that allows the virus to reproduce its RNA. So two very different mechanisms of action, which means that these two drugs in combination might actually be synergistic, that is, may have an outsized inhibitory effect on the reproducibility of and transmission of the virus. There are some other examples of that kind of potential synergism that have not yet been tested. So here are the Retonavir drug interactions that I was alluding to that that are a problem. You can see it's a long list of drugs. I haven't included all of them actually, but if you have atrial fibrillation and rely on amiodarone, you may have to stop your amiodarone. If your hypertension is controlled on amlodipine, you may have to give it up. Or your bupropion if you're depressed, and so forth. Probably the most common one's going to be statins for cholesterol control, and you better not use your Viagra when you're on this drug either, or you're in deep trouble. So there are some special cases in which this is really important. So for example, for transplant patients relying on any of these three drugs to preserve your transplant, you're not going to be able to use Paxlovid. Oh, oops. And of course, it interferes with birth control. So if you're relying on birth control pills, you better abstain for a while, or use alternative birth control. If you've just had a coronary stent, you may have to risk the stent thrombosing, or just not use the Paxlovid. And a bigger problem is chemotherapy, because it interferes with all four of those chemotherapy drugs and a few others. One of my patients with chronic lymphocytic leukemia who was unable to mount any antibody response whatsoever, even after the booster. He and I looked at what he was going to have to give up in order to take Paxlovid, and it was 4 of the drugs he relied on, including his chemotherapy with Imbutinib. So,
excuse me, Dr. Murphy, this is Daniel Panado, the Zoom host. I just wanted to let you know that we've just passed the 10 o'clock mark. Thank you.
And this is my final slide. Thank goodness we made it. So, you know, for those of us who somehow have escaped even Omicron so far in 2 years of this pandemic, we're reminded of this passage from Psalm 91. Fear not the pestilence that stalks in the darkness, nor the plague that destroys at midday. 1,000 may fall at your side, 10,000 at your right side, yet the evil will not come nigh thee. I think that only applied to King David and not the rest of us. As much as we might like to take comfort from the Bible, but I'm sure most of you do not, and so I suppose you can disregard this this psalm. Unfortunately, this is a reference back to the joke with which I opened this discussion. So actually, Daniel, we probably could take a couple of questions. What do you think?
That sounds fine. If people want to
Let's
address you
see.
directly, if that's the way you'd like to take it.
Yeah, we could take a couple. Do you see any in the chat, or do you want to just unmute everybody?
I see people can just unmute them and direct their questions directly too, if you'd like.
Okay, here I am.
Mhm.
Obviously, I did. Yeah.
Oh, this is Leah. I just wanted to let you know there are two questions in the chat from Robin Palmer. The first is, how does anti-polymerase target the virus and not interfere with normal cell polymerase?
Because viral polymerases are vastly different from human RNA is vastly different from viral RNA, and in fact, human polymerases will not work to replicate this virus. So the protection comes from that vast difference. What's the other question?
The second one was, how does government issued KN95 measure up to N95? And then there's a question from Midori.
Yeah, there's very little difference as far as anyone can tell. And in fact, obviously it's easier to get a KN95 than the 3M N95 masks. So I have a supply of KN95 masks, and that's what I use, and it's worked for me, but I'm just an N of one. So I will say that I think the hospital is probably the safest place in town, and that's about the only place I go aside from the office. So I think Walmart's a lot more dangerous, and of course the reason is that the precautions in the hospital are strict and rigorous. I mean, you don't get into the hospital without your mask. Now, it's true that much of the public is wearing cloth masks, and they're less effective, but they get you in the hospital. But at least all of the personnel are wearing much better personal protective equipment than the patients or the public. So.
That's actually a really good segue into Midori's question. She writes, what are your thoughts about the recent removal of restrictions?
Well, scientifically premature and probably politically post-mature. That's what I would say. I'm not sure we could hold off the demand much longer anyway. A visit to Walmart 2 weeks ago and a visit today would probably tell you that. So, I'm going to keep wearing my mask for sure. And I think what we want to see is the test positivity rate come back down toward 5%. We want to see hospitalizations dwindle to next to none before we take our masks off.
And then two more from Robin. Number one, how long will PCR remain positive after infection?
Well, remember the PCR detects the RNA of the virus. And the RNA of the virus is actually remarkably stable and can hang around long after all viable virus is gone. And so, so the PCR is actually misleading as a guide to resolution. And if we look instead for culturable virus, then we find that it's gone within a few days, especially in the case of Omicron. Actually, Omicron's cleared pretty quickly. You know, odd as that might seem. But the RNA detectable by PCR is in many people positive for quite a lot longer. And so in that sense, the antigen tests might actually be a better measure of resolution of transmissibility than the PCR. But the PCR is much more sensitive in detecting acute infection. So that's why we use the PCR, frankly. Now, the efforts to use these tests to determine when people can come out of isolation, that's a little more fraught for obvious reasons.
There are a couple of folks who are unmuted, Linda, Jane, and Jennifer. I didn't know if you had any questions you wanted to pop in.
I do have a question, Kevin. Thank you for doing this today. And
Sure.
I forgot to tune in until the second half. So I might have missed a lot. I might have missed what you said about this government test. Are we confident in the test that the government have mailed us? These are an antigen rapid test.
Yeah, it's not as sensitive as the PCR, so it's going to miss some cases. On the other hand, as I was just saying, it might be more reliable than the PCR in
Right.
you know, telling you when a viable virus has gone away. But it's, you know, it's somewhere around 80 to 85% sensitive in detecting the virus.
Okay.
So
I feel weird as I feel.
it's probably not a substitute for other safety measures. In other words, you know, it doesn't it doesn't mean that you can gather in large groups without a mask.
Okay,
So,
thank you.
all right.
Other questions? Let me just say that the large topic that I completely omitted discussion of was vaccines, and so I'll just make a few essential points now. One is that the first 2 doses of the mRNA vaccines, which were so effective against Delta, are not effective against Omicron, but the booster is, odd as that might seem. So if you've not gotten your booster, Omicron's not quite gone, and you should get it. So, anything less is not yet currently available. Now, both Moderna and Pfizer are developing Omicron-specific vaccines, and right now we don't know whether we're going to need to use them or not. That remains to be determined, I think. But I'm glad they're working on them. So, but Omicron may be gone by the time they're out and authorized. Other questions?
Is it?
Okay,
ahead.
well, I think we're at 1:15 and we need to stop so everybody can get ready for the service. And if you have more questions,
join me in the coffee hour after the service. I'll be glad to answer them then.
Thank you.
Okay, all right.
Great job, Kevin. See you later.
Thank you.